Welcome to Antidotes, Stories in Medicine. This is a special coronavirus episode. I am going to edit this as quickly as possible and get it out. So if you hear some mistakes or the audio is not great, then that's why, because I hate editing, as everybody knows. And I really want to get this information out quickly because this coronavirus information, there we go, first mistake, is changing so fast that what I say in this minute could be changed by the time we're even done recording. So it is Friday, March 13th, 2020 at 11:25 a.m. All of the information I'm presenting you is accurate as of this time frame for what's been available to me. So just keep that in mind. And to talk about this with me is great friend of the podcast, Tina from Good Nurse, Bad Nurse. Hi, Tina.
Hey, good to be here. Glad to be able to talk about this, although I feel like there's so much information out there that I don't really know a lot, but I'm excited because I know how good you are with research and how thorough you are with understanding things. So I'm excited to get to talk to you about it. Yes.
Let me just tell you, I have been driving my boyfriend insane. Like the last few nights, I have been up till 3:00 in the morning reading journal articles and studies and everything else because I'm fascinated by this. And that's why we got into medicine, right? Is to understand diseases and how they work. And I've been going back to molecular chemistry and microbiome and looking at receptor sites and all this crazy stuff and rambling about it to the boyfriend. And he's like, I don't know what any of those words mean. So I'm really excited to talk about it because there's some really cool information. I'm going to say cool as in interesting scientifically. Obviously, people dying is not cool, and that's the entire reason we're in this job. But there's some really interesting stuff. And what's kind of going out in the media is totally different than what we're seeing. So we're going to talk about it. I will put this disclaimer out there. I am not a virologist. I am not an epidemiologist. I am not an infectious disease physician. The information I'm providing you, though, is evidence-based. It is all from primary sources. They're from journal articles that I've done myself or from the CDC or the WHO. I have looked at multiple journal articles to confirm certain things that I'm going to talk about. But of course, some of the things I may recommend or some of the things I may talk about, I'm not necessarily recommending you do. I'm just saying that this is the research that's out there and it's not FDA approved, but this is what's being going on in the rest of the world or what was happening for SARS, which is a sister strain to the COVID-19. So don't go, wow, I heard all this stuff on the Antidotes, Stories in Medicine podcast. I'm going to start treating patients like this. Please don't. Please don't sue me and please don't do that. But go and take a look at these articles themselves because I'm going to list some things in the show notes and there's some really great information out there. So that is my big disclaimer.
Yeah.
First of all, I guess I want to ask Tina, you're working inpatient in a hospital. How are you feeling about this? How is your hospital feeling about this?
Well, it's interesting because there hasn't been a lot of talk about it up until just the past couple of days, because the area that I live in, we did not have a case of it until yesterday. So yesterday was our first confirmed case in Knox County. There has been a few cases. We live in Tennessee, but it's East Tennessee. Tennessee is a long state. So, you can be in Tennessee and be way far away. So we do have a confirmed case here. And so our hospital had been talking about some things, but not, it got serious yesterday. And pretty much they said, no more visitors, no more, it's going to be absolutely necessary family only for our patients. And we know that it is better for patient outcomes to have family there. We know that. And we always want to have that. And we encourage people to be there normally.
Right.
But during this time, we can't do it. So that's definitely one thing that they're doing is they're definitely restricting visitors.
And so the reported cases, that's a interesting thing, right? Because the testing is such a big problem. And right before you and I started recording this, I got an email from LabCorp and Quest, and I was talking with my boss. I do home home visits, house calls as a provider. And there now is a commercial test that's available that you can do through LabCorp and Quest. It takes 3 to 4 days to get it out there,
Nice.
to get results. It's an NAAT swab, so a viral swab, and it has to be frozen and sent to the lab, and you can't get it collected at LabCorp or Quest. And it's nasopharyngeal or oropharyngeal, so nose or mouth. And I'm not, previously the Department of Health wanted you to do nasopharyngeal, oropharyngeal, a combination one, plus a serum tube. That was our guidance last week when I wrote the guidelines for our COVID response, because I was the point person for that. And so now maybe it's just one swab. I don't know. I have to look into this afterwards. But now we have commercial testing available. We're finally allowed to do it. It's not all done through the state labs. So, you may have had one reported case, but I suspect we probably have, I know we have a lot more cases that are out there.
Yeah.
That we just haven't known about because we haven't been testing.
Right.
And also right before we started to record this, I was reading this Medscape article about how GI symptoms may be the preceding symptom and that there's viral shedding in stool. Now, not necessarily infectious viral shedding like you would see with like C. diff or, oh my God, why am I blanking on this? Cholera. But, you can get severe nausea, vomiting, and diarrhea a few days before you develop the dry cough and fever. So we may have been like, oh yeah, you've got a GI bug, and it's actually been a coronavirus exposure, and we haven't been testing that because why would a gastroenterologist be like, let me swab your nose?
Right.
They wouldn't do that. So that came out, I think on the 11th. Yep, March 11th. Early GI symptoms in COVID-19 may indicate fecal transmission by Ricky Lewis, PhD, on Medscape. You guys can go look that up too. So it is March 13th. We'll do a little brief coronavirus history of this outbreak, and then we'll kind of talk about some more stuff.
Okay, sounds good.
So this all started in December with this new weird pneumonia that was presenting in Wuhan, China, right? And then, some doctors were like, hey, this is a really severe disease. We don't really know what this is. It's maybe around some of these fish markets, some meat markets, just some outdoor markets that are there. It started to spread throughout Wuhan. And then I'm not going to go too much in. We kind of know the story, right? And then it started to get really out of control. China was like, no, there's no problem. And then all of a sudden they're like, oh yeah, there's a really big problem. They locked everybody down in Wuhan. Then they locked everybody down in China right around the Lunar New Year. And that actually significantly reduced the spread of the disease. And the US did stop incoming travel from Asia, which did buy us a little bit of time. But unfortunately, we didn't start testing people or develop a test. Efficacious. We didn't get a good test at that time. So we didn't kind of prepare. Now, everyone's really freaking out because we don't want to overburden our hospitals with these severe cases. Now, you're going to hear the naysayers kind of at the opposite end of the spectrum about this saying, oh, it's just kind of like a bad flu, which first of all, it's not. But it can be really mild for some people. The majority of people are going to have a really mild case and they're going to be fine. And this is just like I say with influenza. And I don't mean to say that this is like influenza, but I would say the same thing. It's not about you. Just because you're going to be okay, it doesn't mean that you can't spread it to other people who won't be okay.
Right.
So stay the fuck home. Tina is going to be like, oh, damn it. I do have to edit that out. Stay home. Because if you're getting it, you're spreading it. So don't do that. Now, does this mean you can absolutely never leave your house and you shouldn't, go to the grocery store and you should use all of the toilet paper ever? No. It means social distancing. So be at least 6 feet apart from people. It means don't go to the grocery store every other day because you can never remember what to buy. It means meal plan, order things on Amazon Prime so it's delivered to your house. One person goes to the grocery store on their way home from work and they hand sanitize before they go into the grocery store. You put your stuff on the grocery belt, you're not touching the self-checkout stuff. The person's bagging your groceries and then you're hand sanitizing before you get into your car. You're in your car, you wipe your car down when you get home. That kind of stuff. You do it once a week. That's fine. That's social distancing as long as no one has been sick around you. Now if you're immunocompromised, if you are exposed, then yes, stay home, really limit your exposure. I do think closing schools, big events, I don't think there should be any sporting events or concerts because, there's always the people that are not going to be diligent with their hand hygiene, that are not going to be coughing into their sleeves. They're going to be out there and they're going to spread it.
Yeah.
There was also a preliminary study that came out this week that said that it can last in the air for up to 3 hours and then on surfaces for a couple of days. So I don't necessarily think you should be wearing a mask because we in healthcare need them. But it means, if you're going to be playing outside, quarantine is really hard for kids. Don't go to a playground, go play soccer where there's plenty of air circulation. Go to places that have really large circulating air. Don't go to the tiny yoga studio where everybody's coughing on each other. Go run on an indoor track if there's not a lot of people there and there's a lot of air circulation. It depends on your area. So that's kind of my general, should we be panicking? Yes, we should be taking this very seriously. No, we shouldn't be panicking and buying all the toilet paper.
I didn't understand about the toilet paper. At first, I was kind of confused about how does toilet paper, what does it have to do with that? I didn't understand it. And then I realized it's because people are afraid they're going to be quarantined for long periods of time. And so they want to stock up on things like that. They don't want to run out of toilet paper. They don't want to run out of,
Right.
that sort of thing. So I guess it kind of makes sense. It's not necessary, but I at least I understand why they're thinking. And then I think what happens is it starts a few people get the idea to stock up on things.
Right.
And then all of a sudden everyone else panics, not because they think they necessarily need to stock up on toilet paper because of the coronavirus, but they need to stock up on it because it's going to be gone and they're not going to be able to get it just as, normally. And then it just snowballs into everyone wanting toilet paper. I am in really good shape in this area because I've been using Amazon Prime for the past year or so, and the subscribe and save where they deliver it to your, and so I keep forgetting I keep forgetting to go in there and not order the toilet paper, and so we keep getting these huge boxes of toilet paper, and my husband's like, Tina, we're not in danger of running out of toilet paper. We're in danger of dying from getting overrun by toilet paper because we're
crushed by toilet paper.
We're crushed by toilet paper. We have so much toilet paper. If you guys need any, let me know. We can hook you
Tina,
up.
Good news, bad.
We can hook you up. We'll ration it. We're going to ration it out.
Yeah. So the boyfriend was in the Army. I was in the Army. We never had toilet paper. They always ran out. And so we have those MREs, our rations. They'd give us them all the time. And you get these little horrible, 1-ply napkins that are folded over, especially if you're female and you're out in the woods and you use your MRE napkins. So when this stuff started going down, I was like, all right, honey, we're saving all of our MRE napkins now.
Yeah. You know how to do that.
Yeah.
Experience.
We're just kind of laughing about it because Amazon Prime is still going to exist. Just plan ahead a little bit. Yeah. You may get quarantined for 2 weeks or something, but plan ahead. That's the biggest thing is, use more reusable stuff. I started getting more beeswax wrap and reusable bags and cloth napkins because 1, it's good for the environment. And 2, then I'm not worried about supplies. Yeah. So social distancing is so important, but freaking out is not good for your health either. So.
Well, I think that for me, I've which I guess everyone has done this, but I've sort of had a journey through this whole thing where I started out just not understanding it, not having enough information. I hadn't looked at it, and I was thinking, oh, this is terrible. And then I started reading about it, trying to understand it, and realized or read that it's not, the symptoms are mild. It's not that many people die. You should be more concerned about the flu and things like that. And so I was like, well, that's true. People aren't worried about the flu. And people tend to be like, oh, I can tell you people get admitted to the hospital and I'm doing their admission history. And I'm like, have you had the flu shot this year? And they're like, I don't get the flu shot. I don't get the flu. And I'm just so shocked. And then you have this going on. So then I'm kind of like, why are we freaking out of this coronavirus? But then I have kind of progressed to recently, especially since you kind of were messaging me and sending me information. And I'm like, okay, there's
Of course
definitely,
I was.
of course you are. And I love that. That's what I love about you, Christine. Like everything is so like rational. Everything is, from a point of view of like evidence-based and understanding the real facts. So that's why I love that we're doing this, because I trust your opinion and your, the research that you're going to do. So I feel like there's a balance there. We have to be somewhere in the middle of that.
Yeah. So let's talk about some of the research I did.
Mm-hmm.
And again, most people are going to have really mild symptoms, but mild to moderate symptoms, and can be well managed at home. And this is really where primary care providers, outpatient providers like myself can make a really big impact, because the biggest issue we are going to have, and the biggest issue that's facing Italy right now, is they didn't take any of these precautions, like South Korea did, is they are running out of ICU beds. They're running out of just hospital beds for people. And they're having to make really difficult decisions about who are they using their, ventilators for, who's going on ECMO, because, people are getting really, really sick and it's out of control. So social isolation, aggressive management in early stages, outpatient, may reduce some of the need for, inpatient admission and ICU admission, and hopefully reduce the deaths. The people that are going to get the severe illness are going to get the severe illness most likely. But if we can space out when they're getting it, they have a better shot of survival. And so this is about allowing them the best fighting chance by you not going to, bar class, by you washing your hands really diligently, and by you staying home when you have a fever, which a fever is subjective by the CDC guidelines. You can say, I feel like I have a fever, or it can be a true measured fever. And if measured fever would be anything above 100.4, although the CDC is saying above 100.
Is there anything to, Christine, people who say, so I normally run a low temperature, body temperature. My body temperature is like 97.2 all the time. So if I'm running a temperature of 99.5, you might say, oh, that's not a fever. But for me, it's a fever. Is there anything to, is that an indicator that you do have infection that your body's trying to fight off?
Okay. This is a thing that we encounter all the time, right? And Tina is just laughing her little butt off on on her couch on the other side of the screen. Okay, the 98.6 thing is a myth. It was like this really bad erroneous study that was done like over 100 years ago. You can have a normal baseline of 97.5, just like you can have a normal heart rate of 58 if you exercise a lot, and someone else can have a normal heart rate of 88 if they are just them. So we're trying to indicate a fever as above 100. Usually it's above 100.4. So we're giving them a little bit of wiggle room here of above 100. And your feelings of having a fever. Are you feeling really flushed? Are you getting sweating? Are you getting chills? If you're like, oh, I'm just warm. Okay, well, did you take a temperature in your ear and you've been wearing those really good earbuds? Or have you just been running around stocking up on toilet paper and your face is flushed?
Mm-hmm.
Take a second.
Mm-hmm.
Take a second and be like, does this feel like a fever? Do I have any other symptoms? Panicking and flushing your face and you're using one of those scanning thermometers, it may interact with your results. So if it's 99.5, I would say calm down, take those earbuds out, chill out, and recheck it in maybe an hour.
Yeah, maybe take it a couple different ways, make sure if you're taking it orally, you're not, you don't have anything interfering with it. Yeah.
Right. Now, don't take it 17 times in one night because you're freaking out about it. That's not helpful either. Yeah. But we like to see different readings and we like to validate results sometimes. So if you're not sure, calm down, watch some TV and see if you get something different.
I feel like this is a really good opportunity. This whole thing, isn't it? Isn't this a great opportunity to kind of educate people on some things like that? Like, taking the opportunity not just to educate about the coronavirus, but about body temperatures. And because there are a lot of healthcare professionals that get really frustrated with patients and family members who say my body temperature runs, 97 point whatever. So if I'm 99 point, if I'm even at 100, then I've got a fever. Some healthcare professionals, nurses get really frustrated with people who say that. my thing is, if you have a patient in the hospital and you're monitoring them and you've consistently been getting 97.4, 97.5, 97.3, 97.6, and then all of a sudden you go in there and take their temperature and it's 99.8, I mean, are you going to freak out and be like, no, but are you going to maybe look at some of their other vital signs and say, is anything else trending up? What's going on? What are their white blood cell count? Are you not going to be thinking this could be something to consider? Sepsis, some infection somewhere. You can't just discount that. And that's that I feel like there's a room for education for healthcare providers as well, or for, nurses especially.
Right. So that's a good point. I mean, going back to heart rate, right? So if your resting heart rate is, let's say 64, you're an average, you work out all the time, so it's pretty good at in the 60s. And all of a sudden your resting heart rate is in the 80s. Yeah, that's still a normal heart rate and normal to be resting, but for you, that's a little bit high. Okay. Yeah, maybe we're going to be having a fever. Now, does that mean freak out? Because that's going to raise your heart rate too.
Yeah.
It's a trend. It means definitely definitely quarantine yourself. Now's not the time to go out to the grocery store. Now's the time to say, am I having other symptoms that are correlating with this? Am I now really sweaty? Is my stomach upset? Oh, I am coughing. It may be a quantifiable measurement that clues you into more other symptoms that seem a little bit more vague that you maybe weren't noticing because you're running around doing the rest of your life. Oh, I am really achy. I thought that was just because I was carrying all this toilet paper into the house.
That toilet paper, that darn toilet paper is causing all kinds of problems.
So much, it's all toilet paper. So it may not be a fever, but you can still be sick and not have a fever.
Yeah.
So just, it's just like when I say, okay, you don't have a bacterial infection and you don't need antibiotics. You can still have a viral infection and still feel like shit.
You mean people shouldn't ask for antibiotics for the coronavirus?
Well, we're going to get to that because we will be giving them antibiotics a lot of the time. So we'll get to there.
Okay.
We will get there. I mean, don't ask for things because let us do our thing.
What? Okay. I'm sorry. I'm being ridiculous.
No, I love the devil's advocate nurse here. Okay. So let's get into some symptoms because I'm sure that's what everyone wants to talk about, right? So I mentioned the GI symptoms may be one of those first things that come up, but let's talk about some of the more common things. Oh, actually, I want to talk about some cases first. What our numbers are at. Now, because we just got commercial testing available from LabCorp and Quest and hospital labs and everything, they're doing their own testing. We're going to see a significant jump in US cases. Now, does that mean, oh my God, panic, the virus has spread so much after Thursday and Friday? No, we're just going to be more accurately recording the cases that already have been existing. So that's really important to note. So don't freak out, but take this really seriously. There have been 1,264 U.S. cases confirmed and 36 deaths as of Friday the 13th. I just realized it's Friday the 13th.
I know. Okay.
Friday, March 13th. And worldwide, there has been 132,567 cases with 4,947 deaths. So everyone's talking about death rates, and I'm not really going to even talk about the coronavirus death rate as a whole because it's really hard when there's so many mild symptoms that are not even being, tested to know what the actual death rate is. And that with health systems being swamped in certain places, the death rate is so variable, and it's mostly because of the resource limiting. So I'm going to give you some examples. So in China, as of today, has had 80,981 cases with 3,173 deaths. So with a death rate of the confirmed cases, it's 3.9%. Okay, that's pretty high. That's really high. But again, confirmed cases, there's probably a lot more out there that they just don't know about. South Korea, on the other hand, is another one of those big ones. South Korea has had an amazing response to this because they had SARS a few years ago and they're like, not again, coronavirus. Everybody there is like on the same page. My dad travels to South Korea frequently for work. He stopped traveling there in December. His company works a lot with Samsung, and they're like, nope, if you are not Korean, you are not coming in the doors. We are scanning everybody's temperature. So it was really interesting. Like right away, they just went on lockdown.
Because they know what can happen.
They know what can happen, and the public is all participating. Unlike the US, where we're like, we're fine. I don't know what the big deal is. There's even nurses that I see on my Facebook page that are like, yeah, this is bullshit. It's like, come on, guys. You're healthcare professionals. You know better. But so South Korea has had 7,979 cases with 66 deaths. That is 0.82%.
Wow.
So that's if this is done right. And they're probably testing everybody. They're testing even the mild cases, and then they're quarantining them. That's why the death rate is so low. Now, Italy has 15,113 cases. They did not shut down their discos, their nightclubs, their sporting events. Let's go watch football and everything. They've had 1,016 deaths with a death rate of 6.72%.
Ouch.
Which is, it's just extraordinary, and it's so heart-wrenching, and it's going to continue to go up. The South Korea and the Chinese new cases they're going down. The case rates are going down. And then there's Iran, which has 10,075 cases, 429 deaths, for a death rate of known cases of around 4.2%. So it's between Italy and China. Iran is another more authoritative government, of course, but they're not. They're closer to China. They're starting to lock things down more, but they're not nearly as bad as Italy. But I'm not saying that we need to have an authoritative government, because clearly look at South Korea. Look at what their death rate is. But they're just very, very aggressively treating it. Okay. So it was declared a pandemic this week. And a pandemic is basically an epidemic that is spread over several countries or continents and is affecting a large percentage of the world population. An epidemic is a incidence of disease that is much higher in a local area or region. And, like the opioid epidemic, we're having deaths from opioids significantly higher, in the United States than we usually would. Now, if everyone around the world was dying from opioid deaths, that would be an opioid pandemic. But it's mostly here in the United States, and so we're classifying it as an epidemic. Okay, we're going to talk about clinical presentation, and this is coming from the CDC as well as the Lancet. The Lancet has a great landing page for coronavirus studies, and they are pre-publishing studies that have not been peer-reviewed yet. So, studies have been out, they're pending peer review. They're basically expediting literature for us to look at so that we can kind of get things out fast. And then, pending peer review, they will officially publish them. So, you can see them, but with the knowing that, hey, they haven't been exactly peer reviewed. So keep an eye on that. But there's been a lot of really interesting stuff about the clinical presentation, who's ending up with ARDS, who's dying, and how the disease is progressing. So this is where all of this information is coming from. WHO, CDC, the Lancet, and a lot of this stuff is coming from the researchers in China. So, politically, we have a lot of concerns about China and their humanitarian work, and their basically work camps for certain populations. But I am going to tip my hat to the Chinese researchers and the Chinese physicians and nurses. They're producing a lot of research for us. And, as healthcare providers, I really salute them for everything that they're doing here. So incubation is about 4 days. 2 to 7 is typical, but it can be up to 14 days. So that's why we're having this 14-day quarantine. But if you get exposed to coronavirus, you're probably going to get it around 4 to 5 days, but within a week. It's more common to see coronavirus in men. It's just slightly more. I think it's like 58 to, 42. But I don't know if that's just because men don't wash their hands as much. I'm kidding. I don't know.
No, that's interesting. I wonder why.
Yeah, I don't know. That's also in China. I also wonder if it's if there's cultural things too. Like men are more out in the business world shaking hands.
Oh, in those regions, yeah.
In Iran, women are in hijabs and burqas, and they're not touching things as much as men would be.
That does make sense. I'd be curious to see what happens in Italy, even what the numbers are.
Yeah. So I wonder in Italy, where maybe culturally it's not the same. Maybe women just wash their hands more. I'm not sure. And maybe women are not touching their face as much if they're not touching their makeup. I don't know.
I did not realize how much I touched my face until all this don't touch your face stuff started. I had no idea.
I know.
And I catch myself doing it constantly.
Yeah. I mean, I try not to touch my face because I don't want to smudge my mascara or something, which sounds like the most anti-feminist thing ever. But then I'm I still do it. I'm still touching things. This is a tangent. I went to BJ's yesterday to stock up on food because I don't want to be going out in public, and I know I'm going to be really, really busy with work.
Yeah.
And I was I don't have any chicken, and I don't have any food in the house. And people were really nice, but I was trying to open those plastic bags to put meat in, but without licking my finger first and then touching it.
Oh yeah.
People were very nice and patient and yep, go ahead. And just waiting at a safe 6 feet away. Okay. So symptoms are fever. Around 77 to 98% of people are going to present with fever. Cough, 46 to 82%. Myalgia, so muscle aches or fatigue, 11 to 52%. Now, these are some big ranges, and these are coming from retrospective studies done by multiple different people. That's why we're getting these ranges. And they're from China and South Korea, and so this is what the CDC has come up with after reviewing multiple studies. So shortness of breath is 3 to 31%, but it's going to worsen around 13 days. So if someone is going to develop sepsis, which is the severe blood infection, or ARDS, which is acute respiratory distress syndrome, they're typically going to worsen around 13 days. In the early stages of the illness, some people report sore throat, but it's not as common. In one study, among 1,099 hospitalized COVID-19 patients, fever was present in 44% at hospital admission and developed in 89% during hospitalization. So if you don't necessarily have a fever when you're admitted, those that are admitted are going to develop one. Less commonly, headaches, increased sputum production, so mucusy, hemoptysis, coughing up blood. It's not common. And then GI symptoms preceding. So there's this really cool article of symptoms from the Lancet and progression. And it shows symptom progression and symptom development in patients that survived and did not survive. Fever and cough are the first ones that you're going to get. But then around, day 6 or 7, you're going to start to get some shortness of breath. And then it shows when they get them into the ICU and stuff. So who is at risk for severe illness? So anybody over the age of 55, people are saying 60, but it's 55, 60, it's an increased risk. The average mortality age is 80, and possibly pregnancy. We're not really sure, but it may be a risk factor. And then comorbidities, especially cardiovascular disease and hypertension. So the way COVID-19 enters your body, excuse me, is through, we're going to get into some biochemistry here, it's through ACE2. So it doesn't actually activate this receptor, but it's using this receptor to enter your body, which is in the lungs. So this is very clinical for people. So this is part of the angiotensin, the renin pathway. So this deals with your kidneys, this deals with your lungs. So you have angiotensin converting enzyme receptors in your lungs. You have ACE1 and you have ACE2. And so real quickly, going back to our pathophys days, you have angiotensinogen. It's then converted to renin. Angiotensin 1 is converted by ACE1 and ACE2 into 2 different forms of angiotensin. It's cleaved differently. So basically it's broken up in different ways by these different these different enzymes. And then those 2 enzymes, angiotensin 2 and then angiotensin kind of broken up differently, activate different things. So angiotensin, ACE2, this is terrible. I'm terrible at talking about this. Okay. So the enzyme ACE2 it, when it's activated, it's theorized it will cause vasodilation, so dilating your blood pressure, and hypotension. This is basically getting hijacked by the coronavirus. And through a lot of different mechanisms, it's releasing all these inflammatory markers. Or inflammatory molecules. So prostaglandins, bradykinins. These are the things you kind of see with like an ACE cough and angioedema. And so we're seeing a lot of patients with hypertension with coronavirus. And there was an interesting study that showed that mice who were infected with SARS and were knocked out for ACE2, so they removed the genes that code for ACE2, basically had very minimal lung inflammation when they were exposed to SARS. So there's definitely a role of this receptor. Because these receptors are getting hijacked and there are excessive amounts of bradykinins in the lungs, you're getting a lot of inflammation of the lungs, you're getting a lot of fluid in there. And there's an idea of management that if we can reduce bradykinins and we can increase the degradation of them, we can then limit the progression of the severe disease to ARDS. Are you following me, Tina? Am I making any sense?
Yeah. Is it so? Yeah, it's basically sort of explaining, what's happening is that it's by it attacking our system, it's affecting our blood pressure, it's affecting our respiratory system, causing a lot of these issues. And these people that already have comorbidities, it's just exacerbating things that they already have going on.
Yes, the virus is going into is attaching to these enzymes in your lungs and hijacking kind of your immune system. You're getting this abundant immune response not only to the virus, but you're also through these enzymes triggering, this the renin-aldosterone system pathway. And I think I said it was something different before, so don't at me. The RAS pathway. And that is further perpetuating the severity of the disease. People who have cardiovascular disease and hypertension, they have an issue with this system to begin with. This is why we prescribe ACE inhibitor drugs, angiotensin receptor blocking drugs, because they have issues with the pathway. So when they're getting the virus, which is further screwing it up, they're at significant risk for acute respiratory distress syndrome. So do you want to explain ARDS a little bit to people?
Well, acute respiratory distress syndrome, I think that the way I feel like that most people that listen to I know my podcast are healthcare people. And so when I say ARDS, they're going to know it. I always assume they kind of know, but then I'll explain a little bit. But if I were explaining to my husband, for example,
yeah, we'll do husband examples.
Yeah, I would just say, that your lungs are so full of fluid that your air cannot go through the water. There's water blocking the gas exchange.
Yeah, and there's so much inflammation and pressure on the alveoli that you're getting more immune responses to it. More inflammatory markers like bradykinins are coming in, further instigating inflammation, and that is damaging the alveoli. It's hyperinflating, I believe, and then you're damaging. So high flow oxygen also causes this because it's putting too much pressure on the lungs. You're kind of structurally and mechanically damaging the alveoli and the lungs.
The compliance where your lungs are able to expand and contract, and that obviously is necessary to be able to breathe. Yep. The compliance gets lower and lower, and you're not able to take in oxygen and release CO2, and you have to be able to, that's obviously breathing. So,
Yeah, it's like over kneading bread dough. It's nice and squishy, but then if you beat it too much, then it's really tough. Yeah. And that's basically what happens to your lungs. You're overbeating it with oxygen and therapies and the infection itself. So it's more of a mechanical injury to the lungs as opposed to, the infection.
Are people at risk so if someone who has a history of reactive airway disease or asthma as a child, to where maybe they were in the emergency room a lot, getting breathing treatments, getting albuterol, getting, all those things, which a lot of kids have. But then many kids outgrow that. And so, yeah, they had years of having to take steroids, having to, do whatever they had to do to get through those, if they would get sick, or even with activity. But now they don't really have any issues anymore. Are those people, or is there any chance that those people, maybe their lungs there's any damage that could have been done from those years? The reason I'm asking that is that my son has, for years, he had asthma growing up, but he pretty much has outgrown it. It's not been an issue, but I was kind of worried about it. And his doctor told him that was not anything he had to worry about, that actually his lungs would be stronger because he went through that as a child. And I was looking up everything like crazy, trying to find information on that. And I couldn't find anything that actually agreed with that.
I don't necessarily know that they would be stronger. You may have some very minimal, like slightly below average, if not average, FEV, pulmonary function. It might be slightly diminished, but I don't think that it would necessarily continue into adulthood. Depends on how severe it was, but it wouldn't make them stronger. I
didn't really understand.
I've never heard that.
And I couldn't find any information on it when I tried to look it up. So, and I figure a lot of people probably are going to be wondering, at least if their child does have asthma. So, if your child has asthma, and they get coronavirus,
Well, so one of the good news is, hi, I do science, not English. One of the good things about this is kids seem to be doing really, really well with this. So if they do have asthma, of course, we want to make sure we're managing their asthma, but I suspect it may be because children's immune systems are really robust and they can probably be clearing out these immune factors and these things that are causing inflammation really well. So all of that is to be said. I kind of went on this rambling, crazy person.
The nursing students are going to love you. They're going to be like writing all this stuff down really fast.
I don't think I made any sense about that at all. Go look at the RAS pathway. It enters through ACE2 and basically causes this like cascade of events where you have elevations in bradykinins and stuff like that, among other things. There's other things, but that's one of the big things, because now we're going to talk about management. So kids are usually pretty well off. So that's really good. But most people are not going to require hospitalization, and they're going to recover with supportive care only. But this illness is going to last for probably 2 or 3 weeks, especially for the more severe cases. And the severe viral pneumonia, the shortness of breath, it's going to develop in the second week of symptoms. People are generally going to worsen on days 8 to 9. So with the flu, it lasts, 3 to 4 days, maybe 5, the worst symptoms, but then you start to get better. Not with the coronavirus. You feel crummy, it's going to get worse around that second week. And that's what your greatest risk. So for outpatient providers, we want to really be checking in on people around day 7 and closely follow them 7, 8, 9. If you're making it through day 10 and you're like, yeah, I still feel okay, I'm getting a little bit better, great. You may feel worse, but as long as you're not feeling really terrible. So pregnancy, you're not really doing anything special for management during pregnancy other than, you're limited by the medications that you can only give during pregnancy. OBGYNs may have a different guideline for that, so I don't know. Corticosteroids should not be given unless you have severe COPD, severe asthma, or sepsis, because there's a belief that the steroids prolong viral replication. This was seen in MERS, and so we want to avoid giving steroids and prolonging the replication. Systemic steroids are at the greatest risk, and inhaled steroids are inhaled steroids are less risky, and they're a better option, but they can still have systemic effects, but not as bad as PO. And because we're concerned about ARDS, so the acute respiratory distress syndrome, conservative oxygen therapy is best. We have a target SpO2 of around 90% in non-pregnant adults and 92 to 95 in pregnant patients. We want to avoid that oxygen toxicity. We want to conserve our IV fluids and have conservative fluid management. Limit IV fluids as much as possible because of pulmonary edema that it will exacerbate existing infiltrates and respiratory distress. This is all from the WHO and CDC, specifically WHO for this stuff. And then empiric antimicrobials. So, we're going to be a little bit freer with giving out some Z-Paks on this one because Z-Pak is how we do treat a pneumonia, right? So we need to look at what diseases are actually prevalent in our environment. So there's still flu around. Those tests are taking 3 to 4 days to come back from LabCorp. Yeah, I should be treating you for the flu if I think it may be flu. I should be treating you for a bacterial pneumonia if I think it may be a bacterial pneumonia. We want to kind of be treating, we don't want someone to wait with a bacterial pneumonia for 4 days waiting on a swab result.
So it's not that you're treating the coronavirus with it, it's that you're treating what else it could be.
Right.
Because you don't want to just assume.
The treatment for coronavirus is not a Z-Pak. I'm empirically treating the symptoms, which could be a bacterial pneumonia because that is very common in that patient and in this area.
Okay.
So I would initiate therapy with the appropriate antimicrobial, be it an antibiotic for bacterial pneumonia, be it Tamiflu for influenza, if that is deemed appropriate in that area.
Okay.
The World Health Organization does recommend that. They say don't hold off on those medications because you think this is coronavirus, because those other things are still out there and you can always stop them. There are some medications that are shown to have some benefit in coronavirus specifically. Now, these are not FDA approved for coronavirus. So this is where our big asterisk is about, don't just start doing this. But these are some of these studies that I was kind of ranting and raving about earlier. We are talking about bradykinin mediated inflammation from that ACE2 receptor. And this is why I was kind of going on that rant. We have some pretty common drugs that moderate this. So NSAIDs, ibuprofen, Aleve, indomethacin, aspirin, they regulate bradykinin inflammation and prostaglandins. So if you have a fever and you have some aches and pains, it may be a better idea for outpatient providers to be recommending NSAIDs over Tylenol, because Tylenol is not going to have that bradykinin and prostaglandin activity like ibuprofen would. And so, that's something to consider. Indomethacin, which is another NSAID, we commonly give it for gout, at doses of 1 milligram per kilogram daily total, actually has potent antiviral efficacy against SARS. So coronavirus is SARS-CoV-2, original SARS. This indomethacin is shown to be very effective and antiviral against SARS. So that's really interesting. So if this is true, and we are outpatient providers, and we're saying, hey, I want to manage the body aches and the fever, and I'm going to be giving an NSAID anyways, maybe I should be choosing indomethacin to do that. Yes, there are higher GI side effects. It's not appropriate for everyone, but if I can reduce all this inflammation, reduce the damage in the lungs, maybe these people aren't going to need to be admitted and need to be going to the ICU. So that's actually what we're going to be doing at work now. Is we're going to be my physician partner and I are going to be doing indomethacin with ribavirin and aggressive management of hypertension. But that's just the protocols that we've developed after doing our research. But always do your research in your own places if you're a provider, and tell patients, this is not FDA approved, but this is what our studies have shown, and so we can give you the choice of participating or not in this. So ribavirin, this is an antiviral. It works really well with indomethacin for SARS by impacting viral RNA synthesis and gene expression. And there's been a couple of studies on ribavirin to support it limiting viral growth. Chloroquine, this is used for malaria, right? In tonic water. I was just thinking about this. What is that medication that's in tonic water? Quinine, right? This is the drug of it. So that actually helps with viral entry and fusion as well as viral replication. Now, I'm not saying go start drinking gin and tonics to avoid the coronavirus. I think you need I forget what it was. Someone was saying that you need so many gin and tonic waters to equivocate what you need to treat malaria. But chloroquine helps with SARS. And this is all based on SARS. So this is not on COVID. This is SARS, the sister strain.
So just trying to understand that, because we don't know enough about the COVID-19, maybe understanding the sister
Right.
virus can help
Yeah.
us.
So SARS is still a coronavirus. SARS is just like one branch on the coronavirus phylogenetic tree
Did you say
away
it was
from
COVID-2?
it's so SARS-CoV-2 is the COVID-19.
Which one is
So
SARS?
SARS-CoV-1, I think, is initial SARS. So this is a SARS virus.
Oh, okay.
This is SARS-2, basically.
Okay.
We call it COVID.
So coronavirus disease, and usually in 19 is the year that it was discovered.
Yes, but it's it's very similar to SARS. And so if you look at the phylogenetic tree, so the DNA sequencing of relationship, what we know as the new coronavirus is an iteration of SARS.
Okay.
It's just slightly different. It's very different than MERS, which is the Middle Eastern Respiratory Syndrome. MERS is much more lethal, but MERS is still a coronavirus. So that's further away, though. There's all these charts you can look at. Go look up phylogeny of coronavirus if you really want to. All you fellow nerds. It's pretty cool. There's a lot of them. We get coronaviruses all the time.
Yeah.
There's normal human strains. Like I had someone with a coronavirus like in January, and this patient had like NL63, which is a really common strain. It can still make you really sick, but we have like 3 regular human coronavirus strains that are constantly circulating, just like rhinovirus, just like, adenovirus. They're out there, and we get the common cold with them. But this is obviously the more severe one. All right. So there's also protease inhibitors. So what are protease inhibitors? These are the medications that we are currently using for HIV, and they're very expensive. And this one has actually been studied in coronavirus. So in one of the coronavirus, the COVID-19 in China, they were using Calitra, which is, excuse my pronunciation, lopinavir and ritonavir and Viracept. So Calitra, which is the combo drug, actually reduced the days of viral shedding from something like 2 to 37 days to 24 days. So it significantly reduced it after the initiation of the protease inhibitors. But they're very expensive. So they're not as applicable. It's going to be hard to get those. But ribavirin and indomethacin are fairly cheap. So those are things that we should be considering. All right. We're at an hour. I don't want to ramble on too long about this. People have other things to do in their quarantined lives. More toilet paper to buy. So is there anything else you think we should touch on before we wrap up, Tina?
I wanted to try to touch on the idea of flattening the curve and the importance of the sort of the balance of for people to understand, for those people who are kind of the naysayers that are, I saw someone post on Facebook this morning, like, I'm going to Dollywood, I'm riding the roller coasters, they are sort of taking it like, oh, hey, while you guys are being dumb and panicking, I'm going to go enjoy the world being, having less people, right. Making fun of Disney for closing, making fun of the NBA for canceling ball games and that sort of thing. And I feel like there's definitely, that is an overreaction as much as the overreaction of buying tons of toilet paper.
Yeah. Yeah. Flattening the curve is delaying the spread so that hospitals and outpatient primary care providers, everybody can keep up.
Yeah.
And it's like we talked about with Italy. We want to be able to provide the best, highest level care possible to people. We want to give them the fighting chance. But if we are stretched so thin that we don't have enough ventilators, we don't have enough masks, we don't have enough IV fluids, we don't have time to resupply, it's a war of attrition at that point. We're going to lose because we just don't have, it's just coming at us. And we're further increasing our risk of exposure, and we're going to have healthcare providers going down. So we need to slow the spread. And slowing it means people are going to get better care. They're going to get more access to care, and we're going to be able to give them everything they deserve. And so we're going to have better survival rates. So That's what flattening the curve means. So stay out of Dollywood. Leave Dolly Parton alone. She's a wonderful lady. She does not need the coronavirus.
No, and the thing
But
is, if you do not take the protective measures of just doing the thing, not being ridiculous, but just following the World Health Organization's recommendations,
yeah,
that's not being unreasonable. Following those recommendations, that's not being unreasonable. Don't be going into large gatherings. Do wash your hands. Try not to touch your face if you can. Don't panic and don't overbuy things, but maybe stock up on maybe 6 days or a week supply of stuff so that if you start seeing symptoms, you can stay home and not spread it. And that way, I'm off work, just spring break next week. I took some PTO. I'm off for like a week. And so I told my husband just now, I was like, my son came home because his work sent him home because he has the sniffles. He's got a sinus infection. He doesn't have a fever. He's not achy. He does not have any symptoms. He's just got a kind of like a cold, maybe allergies that's kind of turned into a sinus infection. And because he sounds like that, they would not let him work.
Honestly, I think that's a good idea. I think if we are very aggressive with our restrictions for a few weeks, we're going to contain this. We need to be very aggressive for a few weeks, contain it, treat the cases that we have, and then be done with it. But if we are having people slip through the cracks and going out and re-exposing people, this is going to drag on for a lot longer and it's going to have a bigger impact. So it's really inconvenient. It's really terrible, but
it's hard for people because my son is 21 years old and living at home and he's fine financially. We can take care of him. But I feel really bad for people who, if that was someone who's trying to provide for a family, single mom, single dad,
right,
or just even whoever that's barely kind of making their bills. And then they get sent home for how many days because they got a cold. I don't know. It's kind of scary to me. I worry a little bit about those people.
It is too, but then at the same time, if they maybe are getting a really mild presentation of the coronavirus that just looks like a cold, if they then go to work and they expose all their coworkers who are in the same boat, well, everyone else is in the same position.
No, I get it. I agree 100%. And he's in retail, so he's dealing with the public constantly. So I definitely get it.
It's a rock and a hard place. And
yeah,
I believe in Medicare for all because I think, especially in places like this, we should not be worried about having to pay for treatment for this. And, when you have the buying power of the masses, you can negotiate better drug prices and you can focus on preventative medicine and treat things before they get out of control. But I think there's a lot of people that are going to not be going to the hospital because they can't afford it. And then they're going to be spreading it because they have to. And in a country like ours, that's shameful.
Oh, I agree with you so much, Christine.
It's devastating and we need to do something about it. And I think our government needs to put something in place for protecting, temporary and hourly workers for their wages and enacting some emergency laws about healthcare because we need to make sure people get covered and they get treated because it's their lives. So,
well, I agree. It's a shame, but
yeah. All right. If you have questions for me, I will try and answer them. And, everybody stay safe out there. Wash your hands, use your hand sanitizer, don't touch your face, keep 6 feet apart from people, don't go to big gatherings, play it safe. Be really strict for a few weeks. Let's get through this. Let's look out for each other though. Be kind when things are taking longer.
Yes.
Be kind to people, reach out to people that are isolated. This is really tough for kids. This is really tough for the elderly. Be nice on social media because that's the only human connection a lot of people are having when they're quarantined.
Yeah.
Don't be a naysayer. Take it seriously. But, show some good. Show the kindness and the compassion that we all know that we have inside of us, but show it for everybody. Because this is the time where we can have that go viral, right?
Yeah, and help educate people rather than being kind of snarky and making fun of people because they believe differently or maybe they're misinformed. If that's not going to get anywhere, if you just very nicely, kindly help to educate and tell what showing some evidence-based information, maybe a website, showing the World Health Organization information. Give good information for people so that they might change their mind, not so that you can insult them and make them feel bad.
Right. I mean, you don't need to be printing out studies and slamming it in their face because one, that's not social distancing.
True.
Two, that's probably pretty rude. Yeah. I mean, you also don't need to obsess about this. My boyfriend was like, "Oh, I heard this great podcast on the coronavirus today." And I was like, I have probably read 100 studies in the last 72 hours about SARS and the coronavirus. I'm going to go listen to some true crime podcasts and because I need to take a break. Like I need to take a break from this and I'm going to go walk my dog and I'm going to go work out at home, but step back from this too. Look out for yourself and enjoy cooking at home. Look up some fun recipes.
Yes, definitely. Enjoy the quarantine time.
Yeah. Yeah. I mean, this is great Netflix era. So,
hey, buy stock in Netflix and Hulu.
Yeah, right. All right. Well, reach out to me if you guys have any thoughts. Let me know what you're doing, especially if you're in other parts of the world. I'm so fascinated by international medicine, but also international responses to a pandemic.
Yep.
Reach out on Facebook, Antidotes, Stories in Medicine. Email is antidotespodcast@gmail.com. Instagram is Antidotes Podcast. And let me know what you think. And I hope you guys all stay safe and healthy. And please share the podcast. And Tina, what's Good Nurse, Bad Nurse?
You can find us at goodnursebadnurse.com. You can find us on Instagram at Good Nurse, Bad Nurse Podcast or on Facebook at GNBN Podcast.
Yay. And I'm sorry for all the mistakes. I'm just going to submit this. So there it is. All right. Thank you, Tina.
Thanks.